Greetings. So let's talk about a classification of drugs called the NSAIDs. And uh, when we talked about the arachidonic acid, um, we we talked about arachidonic acid in the anatomy and physiology video. So if you're not sure about that, I want you to go to that section and watch the video on arachidonic acid. But essentially, you have the cell wall, which consists of phospholipid layer, right? Okay. And then if the cells get damaged, you have chemicals that are released, and then you have phospholipase A2 enzyme, which gives us arachidonic acid. And this is a start or the building block for an inflammatory response. And essentially, arachidonic acid gets acted on either by lipooxygenase enzyme or LOX, or it can get metabolized by the Cox enzymes or cyclooxygenase enzymes. Um, and so, following this pathway, drugs that influence the Cox enzymes or cyclooxygenase enzymes are essentially the Cox drugs. Okay, and these are drugs that essentially inhibit the Cox enzymes. So these drugs that inhibit the Cox enzymes or cyclooxygenase enzymes then decrease inflammation, right? And so these classification of drugs are called NSAIDs. So what is NSAIDs? So NSAIDs is non-steroidal anti-inflammatory drugs. Okay, so if you see N, S is steroidal, A anti, I inflammatory, and then D and S of drugs. So non-steroidal anti-inflammatory drugs. So they're not glucocorticoids, right? So they're not corticosteroids, but yet they decrease the inflammation. So they're called NSAIDs. Okay, so that's essentially what we are going to talk about. Okay, so just very quickly, let's go through uh, the pathways of some of the receptors and enzymes very quickly, so that the rest of the stuff can make a lot of sense. So remember Cox-1 enzyme, and again that increases inflammation, fever, pain, and then there's smooth muscle contraction. So that enzyme converts arachidonic acid and then causes some of these symptoms. It can activate thromboxane. So remember we talked about thromb. So it increases clots, thrombus. Okay. So again increases clumping of the platelets. So that's increasing thrombin, increasing blood clots. Okay. And then you have Cox2 enzyme. Okay. And that also increases pain, fever, inflammation, and smooth muscle contraction. And then additionally, there's a Cox3 enzyme, and this is very specific, and this is in the brain. Okay, so essentially, Cox3 works on arachidonic acid and then works in a certain section in the brain which addresses fever and pain. Okay, so these are the three enzymes. We talked about thromboxane. So Cox1 stimulates thromboxane. And then again, Cox1 also activates the prostaglandin pathway. And again, there are several prostaglandins in our body. Okay, several of them. So I'm going to cover the most important and the most relevant one. So that's prostacyclin. So remember cyclin, it decreases the clumping of the platelets and vasodilates. So it keeps that blood cycling, keeps it moving. So if you think about it, thromboxane and prostacyclin or PGI are opposite to each other. And then you have PGE1 and PGE2. PGE1 increases stomach acid, and then PGE2 increases the renal blood flow. Okay, so these are some of the big ones that are there. Again, Cox2 enzyme creates a lot of prostaglandins that come out of the arachidonic acid, okay? And that's the only thing that it produces. Cox-1 again helps us produce thromboxane and also helps us produce prostaglandin. So this is very, very important, and we'll see this in a second. Cox-1 stimulates both thromboxane and prostaglandins, okay? While Cox2 just stimulates prostaglandins. And in a second, I'll share with you why it really makes a lot of sense and how it helps us with learning the drugs and some of their properties. Okay. So again, we talked about NSAIDs, non-steroidal anti-inflammatory drugs. They are not steroids, but they decrease inflammation. So Cox inhibitors. So these are drugs that inhibit this enzyme, Cox enzyme, and by virtue of that, it decreases inflammation. Now, you have three categories of Cox inhibitors or NSAIDs. Okay, three categories. And if you see a drug which is an NSAID, which is not on the list of drugs that we're going to discuss right now, take a look and see which category does it belong to. Because if you can localize the category of this NSAID, you know about 90% of what it does. Okay, and that's how it's going to help you learn things, is you learn the classification of drugs, and the rest of it, once you learn the prototype, you'll get 90% of the information that you're required to have. Anyways, we'll continue with this. So three kinds of Cox inhibitors or three kinds of NSAIDs. The first one is selective Cox-1 inhibitor. Okay. The third one is selective Cox-2 inhibitor. And the second one is a non-selective Cox inhibitor. So which enzyme does selective Cox-1 inhibitor inhibit? Well, you guess it, Cox-1. Okay. Which enzyme does Cox-2 inhibitor inhibit? You guessed it, Cox-2. Perfect. And then the non-selective Cox inhibitor inhibits 1 and 2 both. If you can remember this, these drugs are super easy. Really, let's take a peek. First, let's talk about uh, some examples of these drugs. So again, low-dose aspirin, indomethacin, and ketorolac or toradol are three examples of Cox-1 inhibitor. And low-dose aspirin is supposedly the prototype. When it comes to non-selective Cox-1 and Cox-2 inhibitors, so these are inhibiting both Cox-1 and Cox-2, ibuprofen and naproxen, and ibuprofen is the prototype. Okay, and when it comes to selective Cox-2 inhibitor, celecoxib is the prototype. You have some other drugs in there, such as a common one is Voltaren or diclofenac. Okay. So again, these are some of the very common ones, but like I shared with you, you don't have to stop with those. So what are these drugs used for? So here's the common element, right? When we looked at this, what was common? Pain, fever. Cox-1, Cox-2 causes pain, fever, inflammation. If I inhibit Cox-1, if I inhibit Cox-2, or if I inhibit both, what do you think will happen? It is going to decrease pain, fever, and decrease inflammation. Let's take a peek. It is going to decrease pain, decrease fever, decrease inflammation. Excellent. Okay. How do you know it's working if you give this medication for either pain, fever, or inflammation? Well, pain. We're going to ask the patient, what's your pain level now? They're going to say less after they take this medication. Aha, it's working. If their temperature goes down, fever went down, it's working. If signs and symptoms of inflammation go down, if they have certain diseases where there's inflammation that's happening, and when we track it, it goes down, then we know it's working. Easy, right? I know. Can't make it any easier. Okay, what else? This category of medication, Cox-1 inhibitors, okay, selective Cox-1 inhibitors, they are helpful in decreasing platelet clumping, okay? So low dose aspirin causes the platelets to become less sticky to each other. And that's great because that's why after a myocardial infarction, we want to use low dose aspirin to make sure they're not forming clots, right? That's amazing. Now, the reason is that the question is, well, how about the non-selective COX-1 and COX-2 inhibitors? Do they help with the platelets becoming less sticky? Now, let's talk about this a bit and let's spend some time on this. I really want to talk about this for a second. Okay, so let's take a peek at this. Okay, let's take a peek at this. So essentially, you have the Cox-1 inhibitors, the Cox-1 and 2 inhibitors, and only the Cox-2 inhibitors. Okay, so this would be a selective Cox-1 inhibitor, selective Cox-1 and Cox-2 inhibitors. So these are the non-selective Cox inhibitors, and these are selective Cox-2 inhibitors. So if I say ibuprofen, what are you thinking about? Non-selective Cox-1 and Cox-2 inhibitor. If I say indomethacin, you're going to say Cox-1 inhibitor, right? Excellent. You got it. Okay. So now let's take a peek. Cox-1 inhibitor, it inhibits thromboxane and prostaglandin, right? It inhibits two things. Cox-2 inhibitor only inhibits prostaglandins. Okay. Remember that? Now that you know. So what that means is Cox-1 inhibitor will inhibit thromboxane and prostacyclin. Okay. Something that inhibits both Cox-1 and Cox-2 would inhibit thromboxane and prostacyclin with Cox-1 and prostacyclin with Cox-2. So it's going to inhibit thromboxane once and going to inhibit prostacyclin twice, right? Let's take a look at this. Cox-1, if you just inhibit Cox-1, you're going to inhibit thromboxane times 1 and prostacyclin times 1. Thromboxane is very, very powerful. If you inhibit thromboxane once, it decreases platelet clumping 4 times. Okay. Now, what's prostacyclin? Prostacyclin helps things cycle. So in other words, platelets get away from each other. Okay. So if you inhibit prostacyclin, platelets are going to come towards each other. It's going to prevent platelets from going away from each other, or it's going to make them come together. But unlike thromboxane, it's not as strong as thromboxane when it comes to clumping. So it is going to clump, but it's not going to be as strong with clumping. So while inhibiting thromboxane would decrease the clumping 4 times, prostacyclin inhibiting would increase the clumping by 1 time. So if I inhibit thromboxane 1 time by inhibiting COX-1, it's going to decrease the clumping 1, 2, 3, 4, right? And if I inhibit prostacyclin, that's going to increase the clumping by 1. So what does that mean? 4 down, 1 up. That means net there's 3 down of clumping. So that means the platelets are going to be not clumping, and it's to the factor of 3. Okay, let's see that one more time. Thromboxane. Remember, it causes what? Thrombin formation. So it gets the platelets together. Well, I'm going to inhibit it. So I'm going to prevent the platelets from coming together, right? So low thromboxane means less clumping. Now, usually it is very, very powerful. So it decreases clumping by a factor of 4. Prostacyclin helps blood cycle. So in other words, if you inhibit prostacyclin, it's going to decrease the cyclin of the blood and make the platelets come together more. However, it's not as strong as thromboxane. So it increases the clumping, but only by a factor of 1. So with COX-1 that inhibits both thromboxane and prostaglandin I, prostacyclin, it is going to decrease clumping by a factor of 4 because of thromboxane and increase the prostacyclin and decrease the prostacyclin, which will cause increase in the clumping by 1. So there's going to be net 3 down of clumping. So it's going to decrease clumping by a factor of 3. Okay. Now let's see something that's a COX-1 and a COX-2 inhibitor. So because it's a COX-1 inhibitor, it's going to decrease the thromboxane clumping by 1, right? So it's going to decrease thromboxane by 1. So the clumping is going to go down by factor of 4. Yes, perfect. Now, because it's inhibiting COX-1 and COX-2, it's going to inhibit that prostaglandin pathway and prostacyclin pathway. COX-1 is going to inhibit by 1 and COX-2 is going to inhibit it by another 1. So it's going to decrease the prostacyclin by factor of 2. Now remember, decreasing prostaglandin by a factor of 1 increases clumping by 1. So prostacyclin, if we decrease it by a factor of 2, we increase the clumping by 2. So now, if I give somebody ibuprofen, because it's inhibiting both pathways, I get a net down clumping of platelets of a factor of 2. Okay, so that's a simple way of looking at it. So with low dose ibuprofen, I decrease clumping by a factor of 3. With ibuprofen, I decrease the clumping of platelets twice. So which one do you think will cause more bleeding? You got it. Cox-1 inhibitor causes more bleeding, and it causes, again, these platelets not to stick together. So the good part is if I'm giving this medication, and I don't want the platelets to clot, this would be very effective, such as after an MI for a secondary prevention of MI. If I give somebody a COX-1 and COX-2 inhibitor or non-selective COX inhibitor, it's not going to make the person have as much bleeding. So um, it will prevent the platelets from clumping, but the effect is not as profound as only the selective COX-1 inhibitor. Okay. Now I do want to kind of go over the COX-2 inhibitor in this, because when I do, you're going to say, aha, that makes so much sense. So COX-2 inhibitor inhibits only prostacyclin once. So what does that do to clumping? It increases the clumping of the platelets by 1, by a factor of 1. So what does that mean for bleeding? So this is the part that's very interesting. Cox2 inhibitors, these drugs cause more clotting. While you have COX-1 that causes increased bleeding, you have COX-1 and COX-2 which cause increased bleeding but not as much as COX-1. COX-2 inhibitors are more clot forming. They form more clots. They make a person form more clots. Years ago, there was a medication by the name of Vioxx. So we originally, when this medication was developed, it was developed so that we could be more targeted with our approach to pain management for patients with arthritis and some of the other drugs. The problem was we started to give these medications, and one of these medications was Vioxx. And we started to see patients have a lot of MIs. And the drug was subsequently withdrawn. And there's still probably warnings with regards to this classification of medication and um, its influence on people who develop MI. So again, now that you study this pathway, it should make perfect sense why COX-2 is predisposing patients to forming more clots and causes more issues with clotting and MIs and those kinds of things. Okay, so this is something that I want you to think about and keep in your mind. So again, we go back to what the selective Cox-1 inhibitors are used for because it's so good with decreasing this clumping of the platelets. We use it actually for this purpose post MI for secondary prevention of MI. Okay. How do I know it's working? Oh, patient ain't gonna get another MI after the first one. Okay. With drugs like ibuprofen and naproxen, okay, again, we had smooth muscle contraction with these medications. We can decrease those. So it's also used for dysmenorrhea. Okay, dysmenorrhea. And then again, at the time these lectures were recorded, we still see uh, these drugs, the selective Cox2 inhibitors, especially Voltaren, being used in a topical form for pain management because they are very good. The problem is when we absorb them systemically, that's when we start to run into trouble with clots. Okay. Now, do you see this? So this PGE2 and PGE1. So we're going to start to talk about the side effects. So as we do, we're gonna now talk about a few things with uh, these two things. Okay. So again, we talked about when this medication works and what is it used for. Let's talk about side effects. Remember PGE2 with kidney blood flow and how it increases the renal blood flow? Well, what if I inhibit it? Well, the renal blood flow goes down. So your glomerular filtration rate goes down and kidney function goes down. Very, 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 very important. A lot of patients are on these medications. A lot of people are taking these meds over the counter. As they're doing that, it is actually nephrotoxic. What can a healthcare provider do? Measure I's and O's, input and output. So if their urine output goes down, you worry about their kidney. We can measure their abundant creatinine or creatinine. And if it starts to rise, that's the time to notify the provider. This is a big, big issue. Okay. We've talked about blood coagulation and how COX-1 is predisposes patient to more bleeding. COX-2 selective inhibitor predisposes patient to more clotting. COX-1 and COX-2, which is the non-selective inhibitor, is actually somewhere in the middle in terms of clumping the blood. So that's something to remember. Um, in terms of bleeding. Okay. Um, what else? So again, stomach upset and stomach issues. So again, we can have some dyspepsia, and this has got to do with increased stomach acid because of PGE1. Okay. So that's just something else to consider. So PGE1 causes a decrease in stomach acid. Sorry about that. And so what one can do is if one inhibits PGE1, right, the stomach acid goes up. That's not good. Okay, that can cause a lot of dyspepsia and it can be harsh on one's stomach. It can predispose a person to peptic ulcer disease. Okay, cause GERD. Okay. Very important to know. Now, if I am also giving them a medication that's decreasing the platelets from clotting, it can predispose them to GI bleeding. Very, very important. Okay. So again, that's something else to think about. If the patient complains of stomach upset, again, we can give this medication with some food. And again, if they start to have blood in the GI tract, whether it be tarry stools or hematemesis, then again, that is something that we need to look at and manage and refer to the providers. Okay. So we talked about bleeding, we talked about kidney function and how it goes down. We talked about how it's used to decrease pain, fever, and inflammation. Okay. So I think we've covered a lot of ground with this. Okay. Now let's talk about some other interesting stuff. So remember the pathway of arachidonic acid, which goes Cox and LOX pathways, right? So here's a question for you. Well, what if I give a medication which is a Cox-1 and Cox-2 inhibitor, inhibits these enzymes? Well, then less of the arachidonic acid is going to go to this pathway, and it's all going to go to the LOX pathway, and will give me more leukotrienes, right? Give me more leukotrienes. Okay, so what does that mean? So again, COX and LOX are inflammatory in nature. LOX, lipoxygenase, actually gives us leukotrienes, which the big role of leukotrienes, the big thin leukotrienes do is they go in the lungs and they cause bronchoconstriction, or airway hyperresponsiveness. Okay. So when we're giving these patients this Cox-1 inhibitor and Cox-1 and Cox-2 inhibitors, what is a big issue with that? Well, because of these, the amount of leukotrienes is going to go up and their airways are going to become more hyperresponsive and inflamed. So if they have asthma or another COPD or another inflammatory lung disease where they're already having small bronchi, well, it's going to make it worse. And so you're going to hear about aspirin and ibuprofen and some of these drugs causing to be used in caution with uh, with people and with asthma. And now you know why. Makes perfect sense. So the question is, wait, um, I give somebody a hydrocortisone or prednisone, right? Why does it not do the same thing? Well, hydrocortisone or prednisone is a glucocorticoid. It actually prevents the formation of arachidonic acid, so you don't have enough material to go either in the COX or LOX pathway. That's why those are very powerful drugs, as we discussed in glucocorticoids. However, they've got some nasty side effects. They've got some very bad side effects. Okay, but these ones, once we have the arachidonic acid, if we try to change these pathways, you have more arachidonic acid available for the other pathway, which causes some side effects, and that's something we got to live with, and that's what you get to see when you give somebody a Cox-1 inhibitor or a Cox-1 and Cox-2, which is a non-selective COX inhibitor as well. Okay, something to think about, but it should make perfect sense now. Okay, now let's talk about some more. So like I said, this is actually 90% of the information. So let's go through it one more time. So Nsaids, selective COX, 1, non-selective, and then selective COX-2. We talked about the prototype. All three of them will decrease pain, fever, inflammation. That's good. All three of them will decrease the kidney function, would cause issue with blood coagulation, and would have some level of airway hyperresponsiveness. Now, with blood coagulation, COX-1 will make you bleed like much, much more. COX-2 will make you clot much more. COX-1 and COX-2 will make you bleed a little bit, but not as much as COX-1. Okay? So those were some of the side effects which were more general. Now let's talk about some specific side effects. So let's talk about low dose aspirin. Okay? So again, we talked about bleeding. We observed for bleeding, especially GI, and we called the physician. Okay. Can they have some dyspepsia, GERD? Absolutely. Peptic ulcer disease, these are all things we watch out for. Okay. There's something called salicylism. Again, aspirin is salicylic acid. And if we take salicylic acid, sometimes we can have a syndrome called salicylism, which includes headache, sweating, dizziness, tinnitus. If a patient gives you a cluster of these symptoms while they're on aspirin, that is your cue that they're having salicylism and that the provider needs to be called to stop this medication. So a lot of times on your tests, you'll see a question related to tinnitus. Okay? But usually if it's tinnitus and you're getting to see one or more of the other symptoms, again, that's your cue in the question to call the provider because we are talking about salicylism. Another thing to watch out for, Ray's syndrome, children under the age of 18, generally 4 to 12 years. They have viral illness. So what happens when they're running a viral illness? They've got fever, they've got pain, they're all achy. And what do we tend to give them? Nsaids. Okay? And we may give them ibuprofen, we may give them naproxen, we're going to give them some other drugs as well, but we don't give them aspirin. Why is that? Because if we use aspirin, we've seen very rarely that in some children you may have swelling in the brain. So when you have swelling in the brain, you may have altered level of consciousness and vomiting. Again, it's one of those rare side effects, rare things that happen with a very small number of children. Again, the care is what? Supportive. We don't know, so we just support them while they're going through this. And we call the provider if they start to exhibit symptoms of brain swelling after they're given aspirin for a viral illness. So what do? We prevent this. It's called Ray's syndrome. So we do not give aspirin to children during viral illness so that there's no likelihood of them developing Ray's syndrome. Okay. Now, if somebody is going for a planned surgery, so let's do some critical thinking, right? Somebody's going for planned surgery. You may have that in a question or you may have that in a real life situation, and they're on aspirin. Okay. What do you think will happen during surgery or a bloody procedure? Blood vessels are going to be cut open, you know, there's going to be blood that's going to come out. If the blood is less likely to clot, what will happen to the amount of blood lost? That would go up if a person is taking aspirin. So again, if a patient is taking aspirin before surgery or a planned procedure, call the provider regarding the med. Okay? Critical thinking. What are we doing? We put aspirin and we put surgery or procedure in one room. Okay? Maybe put them together. What comes out? Bleeding. See how we are critically thinking? Excellent. Let's do some more critical thinking. I am giving somebody corticosteroid and I'm giving somebody ibuprofen. Okay? What will come out when I put the two of them in a room? Decrease inflammation. Yep, you would be absolutely right. What else? Corticosteroid. Again, it prevents the tissue from healing, so you get more peptic ulcers. Curling's ulcers. Remember Curling's ulcers? And ibuprofen makes you bleed. Okay? And also causes GERD, increases acid. What does this give you? GI bleeding. See how we are starting to put two and two together? Excellent. Excellent. See, this is amazing. That's essentially what critical thinking is. Okay. Toradol. Remember ketorolac? This is another of the, you got it, non-specific, sorry, Cox-1 inhibitor, right? Which is non-steroidal anti-inflammatory drugs. Cox-1 inhibitor. Again, with Toradol, the big issue is what? Very, very, very good for pain. Unfortunately, it's very, very, very bad for kidneys. So we give it for very, very, very short term. Usually in the books, I think 2 to 3 days, and then we stop it because the GFR goes down or it's got very bad effect on kidneys. Okay. I think we talked a little bit about NSAIDs and steroids. What about alcohol and NSAIDs? So the NSAIDs give you what? Peptic ulcer disease and gives you GERD. What about alcohol? Gives you more of that as well. So again, you have increased stomach ulcer. What if I give somebody heparin and NSAID? Heparin does what to the blood? Makes you bleed easier. What does NSAID do? Make you bleed easier. Increase bleeding. Which is going to make you bleed more? Heparin plus ibuprofen or heparin plus aspirin? Aspirin will cause increase more bleeding than ibuprofen would. Remember, this is non-selective Cox inhibitor. This is Cox-1 inhibitor. So this would be increasing the bleeding tendencies. Wow, isn't this amazing? Now you actually are combining categories of drugs and doing some very interesting thinking just based on some very few principles about this drug that we're stacking up. Okay. Okay. So let's continue. So remember, we went with Cox-1 and Cox-2 drugs. We didn't talk about Cox-3, right? So let's talk about Cox-3 inhibitor. And that's what? Tylenol or acetaminophen, or in some parts of the world, it's called paracetamol. And it's used for pain and fever. That's all it's used for. It's not an NSAID. It's not an NSAID, which is the only NSAIDs. The only NSAIDs are Cox-1 and Cox-2 inhibitors. These are the NSAIDs. Non-steroidal anti-inflammatory. Why is that? Well, Tylenol is not an anti-inflammatory. Remember, it's only pain and fever, not inflammation. So it's used as an analgesic and an antipyretic. Anti-fever and anti-pain, but not for inflammation. So it's not an NSAID. How does it work? Cox-3 in the brain. Okay, Cox-3 inhibits it, prevents, the arachidonic acid from acting on the brain and having fever and pain. Side effects, liver damage. Remember, for Cox-1, non-selective Cox inhibitors, Cox-2, what did that damage? PGE2, kidneys. This one does not damage kidney, damages the liver. Okay? At the time of doing these lectures, the FDA had, well, the guidelines from FDA shared that we need to have less than 4 grams per day of this drug that we need to give to the patients. Because anything over 4 is hepatotoxic. Okay? The goal is to give it as even less than that. Okay? And if they overdose on it or they take too much of it, the antidote is mucomist. Okay? Smells like rotten eggs. Horrible smelling drug. But they get it to try to save their liver. Okay? Now, Less than 4 grams a day. How is this used clinically? Or how can I ask you questions about it? Or actually use this principle in real life on a patient? Let's say you are working in a hospital and one of the orders read hydrocodone 5 milligram slash Tylenol 500 milligram, 1 to 2 tablets every 4 hours needed for pain. This means you're going to give this patient one tablet. It's going to have 5 milligrams of hydrocodone and 500 milligrams of Tylenol. Some people abbreviate Tylenol as APAP. Don't do that in charts. Okay? That means each tablet has 500 milligrams. So if patient has pain and there's order for 1 to 2 tabs every 4 hours, and this is what they've gotten as that drug today. So at 1 in the morning, they got 2 tablets for pain of 9/10. At 6 in the morning, 2 tablets. 11 in the morning, 2 tablets. At 6 p.m., they got 2 tablets. And then at 11:50, they're complaining again of pain. What do? So before giving this medication, we have to actually calculate the Tylenol they have received in the past 24 hours. So past 24 hours would be the day before 2350. So they've received 1 gram of Tylenol at 6 p.m., 1 gram of Tylenol at 11 a.m., 1 gram of Tylenol at 6 a.m., and 1 gram of Tylenol at 1 p.m. So 1, 2, 3, 4. So they've already received their 4 grams of Tylenol. They have received the maximum allowed dose. We do not give another Tylenol dose. We've got to call the provider. You've got to say, look, this is a patient safety issue. Can't give more Tylenol. They've got 4 grams already, man. You got to order something else. Patient safety. See that on your test. See that in real life. Before giving Tylenol, calculate the amount of Tylenol patient has received in the past 24 hours. And it has to be less than 4 grams if a patient is healthy. What if a patient has cirrhosis of the liver? Well, there's actually some more calculations that may need to be done because the threshold or the dosage I'm going to give for Tylenol would be much lower. In fact, there's a high likelihood we would not be giving them Tylenol at all. So again, that would be a patient safety thing. But more on that later. Okay. Same concept applies to Nsaids. Ibuprofen, 400 milligrams every 6 hours. Daily maximum 1.2 grams a day or in a 24-hour period. Same. I'm giving somebody ibuprofen. I got to calculate. I'm giving somebody ibuprofen at home. I got to calculate. Got to do the same thing. Past 24 hours. If they've gotten 400 milligrams at 8, 400 milligrams at 2 p.m., and 400 milligrams at 8 p.m., 12 at night they have pain. I've already given them 1.2 grams of ibuprofen. I'm maxed out. And that's for a healthy patient. I've maxed out 1.2 grams. I cannot give more ibuprofen. I got to call the provider. I got to say I need something else. Do well on your tests. Save a life. What's ibuprofen going to do? Remember, it's a Cox-1, 2 non-selective Cox inhibitor. It's going to damage what? Not the liver. It's going to damage the kidneys. Yep. Okay. So again, you see how patient safety kicks in when we are talking a little bit about these drugs. These are very, very commonly used. Okay. So are there more brands of NSAID? Yes. How do I organize them? Just as I told you, look at the drug book, see which category they belong to. Let me take some examples. Ketoprofen. Look in your drug book. It's a selective Cox-1 inhibitor. So what would it do to bleeding? Much more bleeding. It's going to decrease pain, fever, inflammation, right? It's going to have effect on kidneys. What about meloxicam? It's a selective Cox2 inhibitor. This is going to predispose patient to more clotting. Again, decrease fever, pain, inflammation. Easy, right? Excellent. Okay, so let's do a quick recap of what we talked about. Okay, so that we are all good. We talked about the NSAID drugs, or the Cox inhibitor drugs in this lecture. So again, we started off with Nsaids, which is Cox-1 and Cox-2 inhibitors. So again, you have the selective Cox-1 inhibitor, selective Cox-2 inhibitor, and drugs that inhibit Cox-1 and Cox-2. They're the non-selective Cox inhibitors. And then you have the Cox-3 inhibitor, which is in a category by itself. Okay, that's the easy one. Tylenol damages your liver. It's not an NSAID because it doesn't do anything into the inflammation. It just decreases pain and fever. Causes liver damage. Less than 4 grams a day. Antidote mucomist. Watch out, because one needs to calculate the amount of Tylenol they've gotten past 24 hours. And if it's greater than 4 grams, can't give them more Tylenol. Come back to Cox-1 and Cox-2. Cox-1 inhibits thromboxane and prostaglandin. Cox-2 inhibits only prostaglandins. Okay. We talked about different drugs in this category, including prototypes. All three of them, Cox-1, Cox-2, non-selective Cox-1 and Cox-2 inhibitor, decrease pain, fever, inflammation. All of them do damage to the kidney. All of them increase the leukotrienes and may cause some airway bronchoconstriction. Okay, all of them also change the blood coagulation, but Cox-1 makes the blood bleed more, predisposes to more bleeding than Cox-1 and Cox-2 inhibitor, right? Cox-2 inhibitor, selective Cox-2 inhibitor, actually makes the person prone to more clotting, which is why these drugs we used to give to the patients would help them with pain, but would cause more clotting. These people started to get more MIs and die. Okay. Again, with aspirin, we talked about some specific effects. Salicylism, tinnitus, sweating, headache, dizziness. Ray's syndrome, do not give to children less than 18 for a viral illness. Surgery, watch out because we're going to cut a patient open. Blood loss, call the provider regarding this med before surgery or planned procedure where they're going to bleed. Okay, Toradol, that's another drug within the non-selective category. Again, we can give it, very, very good for pain, very, very bad for kidney. Used very, very short term, 2 to 3 days, stop. Okay, we talked about some critical thinking, aspirin plus steroids, corticosteroids, NSAIDs plus alcohol, heparin plus NSAIDs. Okay, can we give these Cox-1 and Cox-2 inhibitors during pregnancy? No. Some of these drugs cross the placental barrier. They can damage fetus. And specifically in the fetus, they have ductus arteriosus, which is, again, when we do more pediatrics, we're going to talk about it. But that's what keeps the blood circulation going in pediatric patients who are in the womb. We don't want to give NSAIDs to pregnant women. Okay. Okay. So we talked about these drugs, right? Again, with low dose aspirin. Again, platelets, prevent them from clumping, so we can use them after MI to prevent clots from happening. Non-selective Cox-1 and Cox-2 inhibitor, because they help with the smooth muscle contraction, we can give them for dysmenorrhea, help relax those muscles, but yet not make them bleed a whole lot more. Okay. So we talked a little bit about the maximum levels of ibuprofen. Whenever we're giving NSAIDs, watch out for the daily maximums. And if the patient's already got the daily maximum, can't give them more, gotta call the provider. And then again, we use this classification, and any new drug that you have that you've not seen, which is an NSAID, just see what their classification is, and you're going to know about 90% of the information about that drug. That's how easy that is.